Three, two, one. We are live now.
Right. Good evening, everyone. Good evening, good afternoon, good morning, depending on the part of the world that you're in. We welcome all of us, welcome you to this second webinar in its series brought to you by the Bone and Joint Infection Network Asia, the EBJIS Asia Chapter. As you all know, this was an initiative by the European Bone and Joint Infection Society. It's very early days for our network, and the idea is to try and get surgeons, clinicians, ID specialists, microbiologists from across this vast region together onto one platform, network, learn from each other. And that's how we've got this initiative of webinars where it's easy for all of us to log in from across the world and exchange ideas. So this second webinar in our series is on fracture-related infections. And we've got two very, very eminent faculties who would be talking about their protocol and how they manage it. We have Dr. Jong-Keon from South Korea, from Seoul, South Korea. He's a very eminent trauma and musculoskeletal infection surgeon. He's chief of the unit there in Korea Guro Hospital. He's also the chairperson of the education committee at the AO Trauma Asia Pacific level. He's got hundreds of publications to his names, multiple book chapters, over 500 presentations, and he's been doing this since 1999. He's the principal investigator of many, many Korean government grant projects, which focus specifically on bone defects related to fracture-related infections. And that's why we have him and Dr. Choi, who would be sharing their experience, their protocol, and I'm sure there'll be lots to learn from them. We also have Dr. Wonseok Choi, who's the clinical assistant professor at the same Guro Hospital in Seoul, South Korea. He's the deputy director of the musculoskeletal infection service. He's also the deputy director of all the grants and the projects that are happening under their department. He's got multiple authors, multiple publications to his credit, and his main interest, as is for all of us, is fracture-related infections and reconstructions of the bone defects. For this talk, we've got multiple panelists heading with Dr. Ricardo Sousa, who's the current president of the European Bone and Joint Infection Society. And a lot of the credit goes to him and the EBJIS Executive Committee to get this Asian network going and get all of us on this platform. So welcome, Dr. Ricardo. We have a special guest today, Dr. Rajeev Soman, who is not an orthopedic surgeon, but he can communicate with orthopedic surgeons in their language, which in itself, I think, is a huge talent. So he's an infectious disease specialist with special interest in musculoskeletal infections, amongst many other things that he does. He's a consultant at Jupiter and Dinanath Mangeshkar Hospital in Pune, visiting consultant at Hinduja Hospital in Mumbai. He's been a former fellow of the Infectious Disease Society of America. He's the chairman of the Fungal Infection Study Forum. He was one of the founding members of the Clinical Infectious Disease Society and is an active part of the editorial board of their journal. He's authored many books on musculoskeletal infections, fungal infections, HIV, and COVID. We have our other panelists from the Bone and Joint Infection Network, Asian Network Steering Committee. We have with us Dr. Agashe, who's a senior trauma surgeon. He was one of the speakers at the previous meeting, along with Dr. Nilo, who comes from Philippines. He's the lead consultant of the Musculoskeletal Infection Service there. Dr. Liu Yang joins us from China, from Chengdu, China. He's also interested in bone and joint infections, and I complete the group here. Before we move on to the talks, again, a reminder for the 42nd annual EBJIS conference, which is going to be held at the end of September in Barcelona. For all of you who can make the long flight there to Barcelona, I'm sure it'll be a fantastic meeting. Lots to learn across various disciplines. For those who cannot make it across, this is a QR code. Just scan it. There is a virtual option now. You can attend it online, and there's a significant discount given for delegates from low and middle income countries as per the WHO guidelines. So it's an opportunity to learn from the best sitting in your own house or hospital. And if you're from the Asian region, interested in things that we're going to talk about, do fill in the survey form, scan this QR code, and let us know that you want to be a part of this group. So I hand over to Dr. Ricardo Sousa to introduce this second webinar and take us forward.
Thank you, Aditya. It's been your great introduction has made my life much easier. It's a pleasure for me to be here today and host this second webinar of the Bone and Joint Infection Network from Asia. So as you said, I am indeed an orthopedic surgeon. I'm from Portugal, but I'm here today as the president of the European Bone and Joint Infection Society. And this is a society that focuses, of course, on bone and joint infection, but mainly on the multidisciplinary approach and on the structured and protocoled approach of this kind of problems because, well, all surgeons face this complication. Infection is one of major complications after surgery. But if you don't have the tools and if you don't have the knowledge of your infectious diseases partner, of your good lines of communication with your microbiologist, with your plastic surgeon, etc., it makes life much, much more difficult. So it's a pleasure to be here today and see this seed of multidisciplinary approach growing and expanding into Asia. And I hope this will be at least as good as the first webinar. And so that being said, I will just pass the word to Dr. Choi to talk about the fracture-related infection from diagnosis to surgical treatment. Dr. Choi, take it on, please.
Thank you. Can you all see my slides?
Yeah, we can.
Okay, I'll start. Hello, everyone. I'm Wonseok Choi from Korea University Guru Hospital. It is my great honor and my pleasure to be presenting at this protocol-based management of fracture-related infection webinar. And thank you so much for your invitation. Today, I will talk about how we try to manage fracture-related infection patients. We have developed our own treatment protocol, which is based on systematic debridement and post-debridement culture, PD culture. I will go over these concepts in most of my following slides. Then I will share one of our FRI cases treated using our protocol. Most of you are probably familiar with this diagram, which you can see in the latest consensus guidelines of FRI. When FRI is suspicious, by taking medical history and clinical exam, some of the features are confirmatory criteria, and other features belong to suggestive criteria and needs further investigation. When surgical exploration is planned, results can be either belong to confirmatory or suggestive criteria. When two or more pathogens are identified by tissue culture, or microorganism is confirmed in deep tissue, or PMN cell count per high power field is more than 5, the patient is confirmed to be diagnosed with FRI. If you get one single microorganism, it is suggestive to be suspicious of FRI. When you read this original consensus paper, it suggests that you need to take more than three tissue specimens. However, in the actual operation, sometimes it is difficult to decide where to take these tissue samples. In other words, it is not clearly defined how to take tissue cultures systematically. I have another reference. This paper was published in EBJIS by Nuffield Orthopaedic Center in England. They aimed to identify the optimal number of microbiological criteria for FRI. They concluded that more than 5 separate specimens should be collected for tissue cultures to improve sensitivity for diagnosis of FRI and to reduce the risk of missing important pathogens. They also said that by reducing the specimen number from 5 to 3, at least 10% of significant microorganisms were likely to be missed. So with these backgrounds of FRI criteria and tissue sampling, now I will introduce our hospital's protocol. Our protocol consists of 3 stages using induced membrane technique. The first stage is debridement, which we take multiple tissue cultures in a systematic manner. After the debridement, temporary internal or external fixation takes place to stabilize and control the infection. Antibiotics-loaded PMMA spacer is inserted at the bone defect, and soft tissue coverage is done if it's needed. During all the stages, post-debridement cultures are taken, which I will further describe in detail what this means in the later slides. We decide to go on to the next stage based on this PD culture. If PD culture is positive, we go back to the first stage and do the debridement again after 6 weeks of IV antibiotics and 2 weeks of drug holiday. If PD culture comes out negative, we proceed to the second stage, which is a definitive internal fixation with a spacer replacement. If the culture comes out negative again, we proceed to the third stage, which is bone graft. There are two important things in our protocol. First is a systemic debridement, and the second, PD culture. I will explain these in more detail. When we do the debridement in fresh open fractures, it is well known that we need to debride thoroughly in a systematic manner, which is described as from superficial to deep and from periphery to the center of the wound. However, far little is known how to do the debridement in fracture-related infections, such as where to take the tissue cultures or how many tissue samples are needed. I will describe the process of debridement with actual operation room settings that we do in our hospital. Before we begin the operation, we drape and cover the patient first, and then we use one more drape set over the first one. The second drape does not go over the ventilator side, as you see, so that we can just peel it off later on during the surgery. Extra set of surgical instruments are prepared at the corner of the OR to use for the post-debridement culture. After everything is ready, we do the debridement based on the radiological imaging and intraoperative findings by matching the center of the infection. We name the main infected lesion as center and start debridement from here to the periphery. Intramedullary and extramedullary tissues from both proximal and distal are taken and named as intramedullary proximal, extramedullary proximal, intramedullary distal, and extramedullary distal. So we shorten it by IMP, EMP, and IMD and EMD. We take out the infected and necrotic tissue thoroughly, and this is basically how we try to take tissue cultures systematically. The second important step of our protocol is post-debridement culture. By repeating the tissue cultures from the same sites after the debridement, we can evaluate the quality of our initial debridement. Also, as I described earlier, this PD culture is used as a traffic light. When PD culture comes out positive, we go back to the first stage, and when PD culture is negative, we can proceed to the next stage. Before taking PD cultures, we cover the wound with the sterile elastic band and take out the first cover of the surgical drape. As you can see, we cut off the drape and peel it off in an aseptic manner, and it is ready to do the post-debridement culture. The surgeons and the scrub nurse change their surgical gowns and use the instruments that were prepared initially. By using 2 sets of surgical drapes and instruments, we can prevent cross-contamination from the initial debridement. Also, separate instruments are used for each tissue sampling to avoid cross-contamination with other specimens. It is also suggested in other references to use the sampling instruments separately in these days. Now we take tissues from the same sites repeatedly and send them to the tissue culture lab. By the location of these tissue samples, they are named PD center, PDIMP, PDEMP, PDIMD, and PDEMD. So I described our protocol, the key factor of our protocol. So now I'm going to go over a case using our protocol in the management of FRI patients from the first stage to the final stage. This is a 52-year-old male fell from a ladder and had open distal tibia fracture. He was treated at other hospital by spanning X-fix first, and then staged internal fixation was performed. The patient was referred to my clinic 15 months after final fixation. The X-ray showed non-union with bone resorption, and some redness of the wound was observed. Both ESR and CRP were elevated, and all of these clinical and radiological signs and serological results were suggestive criteria for FRI. I took PET-CT to localize the infected lesion and to decide the extent of the debridement. The most hot uptake lesion was at the intramedullary area of the distal fragment. So the first stage was planned as shown to you before. 2 separate sets of instruments and draping were prepared before beginning of the surgery. Systematic tissue culture was done by taking tissue samples at the 5 sites which I described earlier. After debridement and resection of unviable bone, drape and instruments were changed and PD culture was taken at the same sites. And then antibiotics-loaded PMMA spacer was inserted at the bone defect. At this time, I left the posterior cortex, which was united, so I did not use any fixatives. I could close the wound, so there was no need for soft tissue coverage. The tissue culture result of this surgery came back like this, with 4 sites of PD culture positive. The traffic light was red, which means that I needed to go back to the first stage again. I had the patient on IV antibiotics for 6 weeks and planned for another first stage operation after 2 weeks of drug holiday. I resected more bone this time, and tissue cultures were taken just like the first operation. Because there was no stability after taking out more bone at the posterior cortex, temporary internal fixation was done using small plate for stability with PMMA spacer. This time, tissue cultures were all negative, including the PD culture, meaning a green light was given to proceed to the second stage, which is definitive internal fixation and spacer replacement. I decided to fuse the ankle joint in this patient since the distal fragment was too small after the debridement. I used intramedullary nail for the fixation, and PMMA spacer was inserted at the bone defect. All the tissue cultures were negative at this second stage, so the third stage was planned, which is bone graft. Until the third stage, we wait about 2 to 3 months, and the patient starts rehabilitation, including weight bearing. We observe for any clinical signs of recurrence of infection and check the serological markers. So now the final third stage was done. I did bone graft using autologous bone harvested from ipsilateral proximal tibia and mixed with RHBMP2. The patient is followed up for 18 months. By 6 months, some consolidation was observed, and by 12 months, I could get a full union, and the patient has no sign of recurrence of infection until now. So I think there are some pitfalls about our protocol. First, our protocol go through 3 stages of operations. Clearly, multiple number of operations can cause burden on patients. However, we have the patient start rehabilitation and weight bearing after the second stage, since definitive stable fixation took place. Also, we are trying to combine stage 2 and 3, which are internal fixation and bone graft, in the patients with negative PD cultures nowadays. Also, tissue culture plays a key role in our protocol. As you know, detection rate of tissue culture is known to be around 75%, and it takes about 3 to 5 days to get the tissue culture results. If we can use intraoperative rapid detection methods, I think the results of our protocol can be more favorable than using tissue cultures. So to sum up, our KUGH FRI protocol is based on systematic tissue culture and PD cultures. Our protocol consists of 3 stages of operations, which we are trying to reduce the number of operations whenever possible these days. You may find our protocol in this article, which we published 2 years ago. I'm not saying our protocol is perfect, but by using protocol-based systematic treatment, I think our protocol can be a guide map for surgeons as well as the patients. Thank you so much for listening.
Thank you very much, Dr. Choi. I forgot to tell you, everyone, that we're going to be taking questions at the end. So for now, we're going to pass the word to Dr. Jong-Keon for another complex case based on this same protocol of treatment. Dr. Ho, if you please. Dr. Ho?
JK, we can't hear you. I think you're still muted.
I'm sorry.
Yeah.
I'll go back.
Oh, yes.
I'm sorry for that. I'm going to follow what just Dr. Choi have said. And I believe this protocol is not popularized outside my hospital. So I'm going to stress again and again with this introduction presentation the protocol again. But this case is a bit more complicated that even applying this protocol was problematic at one point. So I'm going to share this. And even before I start my talk, I want to mention this specific spirit of team approach here in KUGH. Professor Sung-Ho Jung, who's on the right side here, is the really dedicated, highly skillful and experienced plastic surgeons. And my team and his team have done combined surgeries, more than 100 cases for the past 10 years. Without his dedication and help, we were not able to do this job in most of my patients, especially tibia. And for the past 10 years, I have trained 20 orthopedic trauma fellows. And these are the guys who really dedicated and did the hard work, most of the hard work. When we have a recurrence, they are the ones came at night and do the debridement and all this really hard work. So I'm representing all this collective hard work for the past 10 years. And here's the case, 53-year-old female patient. She was transferred 2 weeks after injury. The initial surgeon did this kind of damage control external fixation and fasciotomy for the compartment syndrome, but debridement was not done, and she was transferred with this status. You can see tibia fibula joint is completely dislocated, and she got common peroneal nerve palsy from the beginning. So we showed you this protocol. So this is the protocol we are working with in these cases. So I did the stage 1 operation, which is debridement. Here in this case, I saw the margin of bleeding and non-bleeding margin. So this non-vital part of the fragments is supposed to be gone, but instead, I used it as a reference for the maintaining the length, because I knew this time with this current situation, we were not able to bring plastics team to do the flap right away. So I knew I need to clean up this time, and then I need another debridement, and then do the flap. That was my thinking. So I knew this was non-vitalized, but I wanted to keep the alignment with this small fragment. And I did my kind of thorough debridement. And proximal tibia was stabilized, and I did the nailing for the femur shaft fractures in one setting. So that was my stage 1 operation. I'm going to focusing on the distal tibial part for the FRI talk from now on. So after my kind of thorough debridement, this is the culture results. So all 10 cultures are positive. So my PD cultures are all positive, meaning that my quality of debridement was not good enough, or kind of I failed to clean up the infected tissue very well. So this is a kind of an easy decision for us. PD cultures are positive, so we go back to the stage 1. So I'm going to do the debridement again. So while I cannot go bring back the patient every day under the general anesthesia, so for a few days I did manage the wound with the vacuum, and then we couple of times, and then I did the second debridement, stage 1-2, and then now I debrided a bit more devascularized wedges, and then still the length was maintained with this small fragment. And I was thinking I'm going to resect this part at the next time when I do the definitive fixation. So after this debridement, the PD cultures turned out to be negative. So I plan to go to the stage 2, definitive fixation. So I did the nailing like this. And then once I done the nailing, I know the alignment is correct. So now, once the alignment is maintained with the nail, then I resected the devitalized fragment so that I didn't lose the alignment. So this was all planned from the beginning. Kind of a little bit of violation of the principle. And then was nailed, and then mortise restored this way. And then my plastic surgeon, I did all this nailing, and then my plastic surgeon back then start this flap after lunchtime. So his flap surgery go on over the midnight. So it was really, really hard procedure. So nowadays we do these two procedures separately. I do this in one setting, and then a few days later, my plastic surgeon do this flap starting from the morning. So it's a little bit different. But back then, we did all these procedures in one day. And so he did cover this major portion of bone exposure with this ALT flap. And then later, this part, muscular part, was covered by the skin defect. And I made a mistake. You can see here, I found out the valgus malalignment at the distal fragments. And after this, this procedure, whenever we do the procedure under the general anesthesia, we do take the tissue cultures, pre-culture and post-debridement culture always. So this time, PD cultures were negative, fortunately. So, but I had to do one more surgery to correct the malalignment. So that was unplanned surgery, but I had to do it. So big surprise came after this unplanned revision surgery. I took the screw out, plate out, and then just correct it, and then cement replace. But because of this was another procedure around that area, I did send the culture again. But to my surprise, previously the PD cultures were negative. and now it's covered by the plaque. Clinically, it was okay. But after this procedure, I got 5 PD cultures, all positive MRSA. So this is a really, really uncomfortable situation to be in. So you just follow the protocol. So initially, it's relatively comfortable for us to go back to do the debridement again. We know that. So repeated debridement, kind of. But I went through this path, PD cultures negative, flaps done, and then definitive fixation done. And then now what? We have PD culture positive. So according to the principle, protocol, I'm supposed to go back to the stage 1, taking all these implants out and start all over again. And emotionally, it was really, really tough decision to do that. And when I had a discussion about this option, patient was really, really reluctant to go through another major surgery. It was really devastating and very emotionally upsetting situation. So we made a decision that we keep the implants, kind of retention protocol, not protocol, retention principle, and then decided to prescribe antibiotics like this. And then she was doing okay. And even the fibula got healed, femur shaft got healed, and she was doing fine. And there was a still cement spacer needs to be replaced with the bone graft, but she was doing okay. So the time goes by almost 8 months. And then 2 months later, after that clinical follow-up, now we have a sudden spike of ESR and CLP. And now I had to go back to the debridement again. So I should have done this made this decision 10 months ago, but it was emotionally really, really difficult decision. And I'm paying the price. Open it up, sure enough, there was a pus collection. Previously, 10 months ago, PD cultures were all positive. I was trying to suppress and kind of hiding my eyes to the fact and then hoping that it is gone. And I had to, this is the situation around the nail, and it all got infected. It didn't go away, even with a long period of antibiotics. So this is the debridement. I took the nail out and placed the thread, cement-coated threaded rod. This is a little bit of side story. We published this paper years back. You can make a threaded, cement-coated threaded rod from the elysium set like this, and then you can avoid delamination of the coated nail. And then especially when you have an infection after plating, you resect, and then you want to have some intramedullary temporary fixation like this, then you don't need to open up the entry, which is not infected. So you make one threaded rod placing up and one down, and you assemble with the hinge and then place the cement spacer. Then you can have a very nice intramedullary temporary threaded rod like this. So you may consider this. We published this in injury paper 2019. And go back to this story. After this, stage 1 again. Now this is third stage 1 again. And then now what? We have one PD culture positive. It's dicey, only one culture positive. But now I learned the lesson very hard way. Previously, PD culture positive, I tried to suppress it and failed, devastating failure. So even if nowadays, even if there is only 1 out of 5 PD culture positive, I go back to the stage 1. So one more debridement like this. And then now the cultures turned out to be all negative. So now we're ready to move to the definitive fixation. So I did it. And the distal fragment was very, very small. And cement spacer placed around. So now, after this definitive fixation, was already 7th operation, and now it's ready to do the bone graft. But you can see the size of the distal fragment is so small, and she has a foot drop. So I suggested ankle fusion, but she refused to do that. She still wants to have her ankle joint kind of mobile. So what I did was I cut the cement spacer right there. So I left some cement around the interlocking screw so that I get stability instantaneously. And then I fill the defect with the bone graft, half autogenous bone graft. Now I'm using RHBM2 mixed with autogenous bone graft. And then graft was placed even over the cement spacer like that. And then this is the her status. Just 5 weeks after this bone graft, I was able to allow weight bearing. And then 3 months down the line, to my surprise, she came back walking without aid. And X-ray shows in just 3 months, breaching on the lateral column already. And then you can see the sequential change in just 5 weeks, start cortical lesion, and 12 months, it's completely consolidated. And there's some amount of cement spacer is completely buried under the cortex now, like this, in 12 months. And she's infection-free 4 years now. She walks, she has foot drop, but she's functionally very happy. So again, like Dr. Choi mentioned, we've been using this protocol for the past 10 years. The definitive fixation based upon post-debridement culture. For us, it provides a logical guideline for difficult decision making. Thank you very much. It's open for the discussion.
Great work, both Choi and JK.
Yep.
Great cases. Great
Thank you.
cases.
Yeah, indeed. Congrats. Well, we got some interesting concepts here on post-debridement cultures. We do have an ID expert present. So before we open the floor to questions from the audience, Aditya, you are accessing the questions from the audience, right?
Yes. Yes.
Before we open the floor to that, Dr. Soman, I would like to hear your opinion on this concept of post-debridement culture. So it seems like we don't need antibiotics because the aim is to get no bacteria there after the debridement. So what's your thought on that? Is it possible to cure remaining bacteria left behind with antibiotics?
Yeah. So I think it's a wonderful concept, and it's totally new for me. I'm sorry I was not aware that you have been doing such good work for in the last decade or maybe 10 years. A few questions in my mind. Now, the first one is, you have proposed, at least in the first case, that you may want to do something more than just the routine microbiological cultures. So what naturally comes to our mind is a multiplex PCR or any such kind of a test. Now, as my understanding goes, that test is very, very sensitive, although the multiplex PCR is only going to have a limited number of PCR targets. So there might be some organisms which are not figuring in that particular multiplex PCR, so that we might miss them. On the other hand, the test may be too sensitive because that may not represent actually living germs. So it might just be the DNA there. That was one of the things. Secondly, when you are doing it second time, after local antibiotics have been placed there, what would be the yield in culture? Is that not likely to affect the yield in culture? So that is one more question. Then, as regards your second case, which is of course very complex, this Acinetobacter was not there in the first instance, so it has come up later. So I take it that it has come from lavage fluid or something like that. The second organism which was found was a MRSA, which again wasn't there in the first place. So has it come from one of the healthcare, some member of the healthcare team? So that is one more question. Another question is the patient did receive chronic suppressive therapy for about 4 or 5 months. Uh, Naturally, because there was a reluctance to do the debridement again. So which was the drug which was used for that? So these are some of the questions which come to my mind.
Okay, thank you. Great points, all of them, I think. Wonseok, you want to take one of those questions? I think you asked something about the first case, right?
The
Yes.
PCR.
Yeah.
So I think
PCR was one, and whether the presence of local antibiotic will hamper the detection in culture, because we are relying on the second, because there is local antibiotic placed already, and now we are going to do the post debridement culture. So will that reduce the yield of the organisms in culture because of the presence, whatever residual local antibiotic might still be active?
okay, so thank you for your question. I we mix vancomycin with the PMMA spacer, and gentamicin is already inserted in the cement. Uh, we don't think that our debridement can be perfect, and we cannot get rid of all the bacteria. So the local antibiotics should be helpful to decrease the pathogen. Sometimes the tissue culture, some of the cultures, they are the microorganisms, they are resistant to vancomycin, but it is very difficult for us to choose antibiotics when we mix with the cement. So I think that's one of the limitations using the local antibiotics. But in my opinion, it is.
My question
let
is
me-
not related, Dr.
yeah.
Choi, to whether you should be using a cement or antibiotic loaded cement. Certainly, you should be using, I think. But will the presence of the antibiotic reduce the yield in culture? So we might get a false negative culture even though the organisms are there. That is my question.
Yeah, can I ask that
Yeah.
question as well? That's a great point. Actually, I never thought about that aspect. Honestly, I've done these lectures many times in many occasions. So I was asked many questions, but this is the first time you raise up that point, and thank you for that. And I think it might hinder the yield of the tissue culture because the local antibiotics is suppressing the antibiotic, the bacteria around that site. But still, the purpose of placing antibiotic-loaded cement spacer is that to kill the bacteria. That's the primary purpose.
Absolutely.
And then we get the very high concentration level locally without systematic
Right.
complications. But I get your point. There might be that downside, but treatment effect with placing cement, AB loaded cement is much bigger. So
Right.
we
The
will probably
benefit,
use
the
that.
benefit definitely outweighs the possible lesser sensitivity of the culture. But the benefit definitely outweighs that. I perfectly understand. This was just something which crossed my mind. That's why I brought it up.
Okay.
And the
thank
other
you.
thing is, if we use PCR, what do you think will happen? Will it be super sensitive? Will it pick up some junk, or will it be missing some organisms? Because at least I am familiar with the bioMérieux PCR, which is multiplex, which does include many organisms, but DNA and primers for different organisms. But obviously, all of them can't be there in that panel. Most notably, even coagulase negative staph aureus is not there. Coagulase negative staph is not there. Acinetobacter is not there. So these things would definitely be important limitations of using that multiplex PCR.
Yeah, actually, I tried PCR for about 20 patients for research purposes with the grant support, because it's very expensive first,
Yes.
and then the second is like you mentioned, there are full spectrum of bacteria identified, so we cannot pinpoint which one is the causative organism in that situation. So I kind of gave up on that idea after trying 20 cases.
You have 8 specimens for every surgery.
Yeah,
So that's definitely going to be very expensive.
Dr. Choi's presentation, he showed one culture specimen. Actually, there is a 10 bottles, not 5 bottles. That was the for the PCR study during that time. And then what was the other question?
The other question was about Acinetobacter and MRSA. So these were not there in the initial cultures or debridement. So these probably have come up after subsequent procedures. And MRSA, I would think, is coming from some healthcare workers, maybe nostril anterior or something like that. Then what was the drug? I mean, we do resort to this kind of a chronic suppressive therapy for, for want of anything else. Sometimes the patients are just not fit for removal of the implant. They are not willing and various other things, in which case sometimes we resort to something like an chronic suppressive therapy, which could be indefinitely long.
So for that,
that chronic suppressive therapy may fail, the patient may again develop a sort of a flare up of that infection, in which case it may be a little easier for the patient to accept the next debridement. But I mean, I am sure you have experience too of some patients doing rather well with chronic suppressive therapy. So I was interested to know which drug was used for that MRSA.
Yeah, thank you for that. And because Dr. Choi and me are orthopedic surgeons, so we stressed all about surgical aspect of this protocol. But there is a mention in the protocol antibiotics. But I totally depending upon infection specialist recommendation. I always consult.
That's fine.
So I cannot answer which specific antibiotics, but and next time we can invite our junior infection specialist to listen her thoughts and philosophy about that. Thank you.
Right. But otherwise, it's a very, very thought-provoking and wonderful concept, and I hope it really stands the test of time.
Yeah, thank you. Thank you very much. And one point I'd like to add about antibiotics is that when we do the stage 1 and flap together and we get the tissue culture and PD positive, and the next procedure will be at least 2 months down the line. So we have 6 weeks IV antibiotics course of the treatment while we are waiting for the next procedure. And then we typically take 2 weeks of 2 to 3 weeks of drug holidays before we move to the second debridement, stage 1. Right. So that's typically what we do.
Yeah, I think that is a standard practice, which at least 6 to 8 weeks of IV or whatever therapy, although now there is a push for giving oral drugs whenever possible. But in these circumstances, I would fully agree to give high dose intravenous antibiotics, which are going to have definitely efficacy against whatever organisms have been found. And then giving that 2-week holiday or antibiotic free period also encourages, in case there are any live germs there would be detected in culture. Absolutely fully acceptable practice.
Thank you.
Thank you. Thank you so much, sir, for these very, very interesting and ID-oriented questions, which most of us will not be able to come up with. I think we have some questions from Agashe, sir. Dr. Agashe, if you could I think the
Yeah.
first question is for Dr. Choi.
First and foremost, fantastic work. Thank you for informing us about this. Dr. Choi, do you routinely do any special imaging like PET scan if the PD cultures are positive? And then you are planning to operate after about 8 weeks, because 6 weeks you will give IV, then you'll wait for 2 weeks. So before that, do you routinely do PET scan or MRI, whatever is possible?
Thank you for your question. We started using taking PET CTs a few years back because we think that taking PET CTs, it can reduce the metal artifact which we can see in the MRIs. So to answer to your first question, I think if I take any imaging before debridement, I think I don't need to take another imaging study because I have the PD cultures are positive, because I cannot exactly locate the infection, but because we localize and name the culture by IMP or EMP like that, so I can, when I go back to do the debridement, I can more focus on the positive region. So I think based on PD culture, if the PD culture is positive, I don't routinely take another imaging studies because of that.
So you have a couple of more questions for Dr. JK, I think.
Yes. To continue the same thing, if the tissue culture is positive in 75% of the cases, that means in 25% of the cases, the culture is likely to be negative, even if the area is infected, right? So taking such a big decision based on that, have you faced any problems?
Yeah, I have many problems, of course, because even following all these protocols, we have 15% recurrence rate. It's not perfect at all, honestly. We published that data in that paper. Right. And even if we take 5 tissue cultures, it's kind of sampling. It's like you cannot send whole tibia to the tissue culture. So there will be false negative result. It's possible. But previously, before I started using this protocol, what I did was I made a decision by kind of gut feeling. It looks okay, and you might need another debridement. That was what I did before, 10 years before. So since I started getting more and more infection patients, I wanted to do it more in a consistent way, same manner. Without this before this protocol, I tend to make a decision differently in different occasions without any guideline. So sometimes it's successful and sometimes it's not successful and sometimes not successful, but I don't know why. So that was the issue. So the more and more patients came to my office, I decided I had a need to develop some guideline for myself and my patient and my whole team. Now it's very comfortable for us because even my junior residents know what will be the next procedure. So it's very easy to have a conversation with the even patient and family. Right. So it's not perfect. It's a kind of a logical, reasonable guideline for us.
Great. A thought-provoking thing. I think, Dr. Menon, I think Nilo or Louis, if they have some questions, and then I'll take my last question.
Yeah. Dr. O and Dr. Choi, congratulations. And I think you're really doing great work there especially in our part of the world, in Asia. My question is, if you seem to rely heavily on musculate technique for your bone reconstructions, would you have like a limit on the size of the defect which you'd apply the musculate technique? Would you do any other, technique
Transport.
for reconstruction of larger defects of the bone?
Good point. Today, because of the limited time, we just focused on infection management with the FRI protocol. But the reconstruction of the defect is a huge topic, of course. And we do mass clay 100% cases. And our record, 20 centimeters, tibia shaft, femur shaft. For 10 centimeters, for us, it's a mass clay. Next time I'll present only focusing on that aspect, because it's a lot of talking points there. And now I'm using RHBMP2 as a additional graft material. So for my cases, for my case presentation, I mixed autogenous bone with RHBMP2. It was one of the 24 study KFDA enrolled approved study cases, which Dr. Choi recently published in injury paper. We had a great result in terms of bone healing. You saw that case in just 5 weeks, started making cortical bone on the lateral side. In just 3 months, it healed. It's really healing fast. So the mass clay we do here is kind of a bit different from what has been published. So there will be a lot of more talking points there. So my record reconstructing bone defect was 20 centimeters. If you ask me the centimeters, its record is 20 centimeters. Next time we'll share that. And my point is I converted from transport to mass clay. For the previous 10 years, I used to do transport a lot. But technically, it was really challenging. Many issues, pin site infection, prolonged fixation time. I do use transport over nail technique to reduce the X-fix time. And when you're trying to place the pins around the nail, technically it's really challenging. And I got very frustrated moment during the surgery. So that technical aspect and the X-fix time made me to turn to this mass clay technique. So I pretty much don't like to place X-fix to my patient if it is not temporary measure. So that's my philosophy. If you give me another opportunity, I'll share the reconstruction of the bone defect part next time. Did I answer you? Sorry, I cannot show
thank you for
you
that,
the
doctor.
presentation. Yeah. So it's
Just for perspective, because in our institution we rely heavily on bone transport. Since
that's totally
for one,
fine. Yes,
we do not have the bone graft substitutes readily available, and it would be quite expensive for us to use them. So we rely heavily on external fixation and bone transport for our bone reconstructions.
Yeah, I've done that previously. Yes, it works.
I guess my last question would be, since you do take quite a lot of samples for cultures, does this not, in terms of costing, when I first introduced the concept of multiple sampling in my institution, that was a big question that I was faced with, because most of the it's quite expensive to have tissue cultures, and I want 5 of them, and you're doing like 10 of them, so that's expensive. Yeah, do you have any challenges about that?
Yeah, when I first presented this 10 tissue cultures in TraumaCon Mumbai by Zoom. Indian surgeons was almost yelling at me, how much money did you spend for 10 tissue cultures? So I know.
JK, we threw a fit actually. We threw a fit. We had epilepsy.
So, yeah, I know. Initially, there was a resistance from the institute, but I just insisted that we need this because I wanted to take tissues from that 5 specific sites: proximal, distal, intramedullary, extramedullary, center. It's just 5. I cannot take 3. So I persuaded. And somehow, 2 years back, the Oxford group, the British group, published 5 sites is better than 3 sites. So I was lucky, not knowing that group did that study. So I really thank for that group for supporting my 5 sites is better than 3 kind of thing. So for our institute, it is now tolerable and acceptable, but I clearly understand the cost issue in different settings. So then you reduce the number of tissues, like just 3 sites, proximal, distal, center, or even you can just collect tissues from 5 sites, but send it as a 1 tissue culture. That if the economic restriction is so are high, then you may do what you can do best in that situation. Yeah, I'm lucky.
Thank you for that. Thank you for that, Doctor. Thank you.
Yeah, thank you.
Dr. Ricardo, do you have a question there?
Yeah, again, congratulations on the excellent work. I just have so this is groundbreaking concept for me, the post-debridement cultures. And I would really like, because all your rationale, all your decisions are based on that post-debridement culture results. And I'm just thinking I would need to reflect some more about this, but traditional teaching is you have to get rid of all the dead infected bone, but the living bone, even if it's got some bacteria in it, if it's, as long as it's living, as long as it's well perfused, and you have appropriate antibiotics, you can get rid of the bacteria. So this protocol you've shown is great for segmental defects, but there are some other more simple types of fracture-related infections where you don't have to make all this segmental debridement, and you still can go on and have a fracture healed and infection cured without removing all the living bone. So does your protocol also involve like debridement with implant retention and for those less complex fracture-related infections, or you just remove everything in every case?
Yeah, thank you for your great point. So the cases we presented today is kind of a representative cases that can explain the protocol the best way. So that's why we pick up the segmental resection cases. But we do not just resect bone right away. We start take out bone that's not bleeding. So even in my case, I didn't resect from the beginning. I maintained the even non-bleeding bone, trying to use it as a guide for the keeping the alignment, restoration of the alignment. So in the end, I ended up resecting the bone segmentally. So I do not automatically resect and then take cultures from the 5 sites. I don't do that. And then those minor cases, sometimes I send tissue cultures from 3 sites. When you have a small gap, how can you get the tissue from 5 sites? So in that situation, you make a reasonable decision taking tissue cultures from a reasonable location based upon your decision and experience. That's totally fine. But the final point, when you do the stage 1, do I choose retention surgery? Mostly not. When I do the debridement, I take the implants out and then do the debridement. Only exception, I keep the keep the implant while I'm doing the first debridement, is that acute postoperative infection within 2 weeks, healthy patient. In that situation, I tend to keep the implant and do the debridement, and then to see if it works. And if it doesn't work, I take the implant out, redo the debridement, and replace the implant. So my retention strategy is very, very limited cases. And most of my cases are referred and already old cases. So for those cases, implant removal is by default. Thank you.
Thank you. There are quite a few more questions from the panelists. Dr. Ricardo, I think you're in the middle of your workday. This will go on for, I think, another 10 minutes or so.
I'm really in the middle of my workday. You're correct.
Yes.
But thank you for having me. It's been a great discussion. Thank you, everyone, for letting me know your protocol. Thank you.
Thank you.
Thank you very much. Thank
Well
you.
done. So the next question is from Dr. Liu from China. I think he's asked, in the second case, the fibula wasn't fixed. Was it to get the tibia aligned a little more and ignore the fibula? And what about the proximal tibia fibula joint?
Yes. Let me see the X-ray for me. Because the flap was covered in more of a transverse way, I was not allowed to make an incision over the fibula. So that's the reason why I kept the contact between the major fragment of the tibia, so that I can make it sure the alignment of tibia is okay. Fibula was kind of ignored. Proximal tibia fibula joint is completely dislocated, and at one point there was an infection as well. So I had to accept as it is dislocated. But for the distal tibia fibula joint, the mortise was actually disrupted. So that's why I brought fibula down and tried to reduce the mortise congruent and place the K wires there. So that's how I was able to save the ankle joint at least. But she had foot drop and it didn't recover. Okay.
All right.
Thank
Thank you. Thank you. Dr. Agashe, you had a couple of more questions if you want to take that on.
Yeah. How often the culture, these 10 cultures are almost similar? So I'm just thinking, because can you combine these samples so as to reduce the cost? Finally, we have to keep thinking about the cost in our country. So is it worthwhile combining 5 samples from one side and 5 samples from other side?
So you mean
rather than taking 5 you collect from 5 different areas, but combine them so as to reduce the cost.
What's your opinion, Wonseok? You wrote that paper.
May I
So,
express something
please.
here?
Please.
Yeah. See, there what will happen is you will not have the specificity. Because supposing, there is some contamination in one of the specimens, then it becomes very difficult to say that whether that is the true organism or not. Supposing you get just see if it is 1 out of 5 is positive, you might still think that this could be a potential contaminant rather than a true pathogen. On the other hand, when you get 4 out of 5, 3, even 5 out of 5, your confidence that this is indeed the true pathogen is like almost 100%. In fact, that is the reason why you have change your gloves, change your instrument to obtain the specimen at every, means every specimen is obtained with a new set of gloves and instrument, isn't it? That is for the same reason that you don't want the same one to be contaminating all the others. So I think in the whole scheme of things, Dr. Agashe, if the patient is, I don't think the cost of culture is so much higher that you should not be doing it or lumping all of them together or something like that. Compared to the 4 or 5 months, maybe 1 week, 2 weeks, you stay in the hospital, the cost of IV antibiotics and everything else, supposing you have this kind of thing that 5 out of 5 are negative, there is so much more confidence in your successful debridement that your need for giving that antibiotics or even following it up with a chronic suppressive therapy and everything goes down. So you will, I mean, it looks as if you are doing going overboard and asking for 5 and 10 cultures and all that. But if you really see the actual cost of the culture compared to the rest of the cost in perspective, I don't think it matters so much.
I think Dr. Agashe is playing the devil's advocate here. He himself is a proponent of sending multiple, but what he's asking is
Exactly.
what
See, I will
everyone
draw the
asks.
analogy with, say, infective endocarditis. It is so very important. Now, it is such an important disease, and I'm sure the things that you are talking about are also equally important, where the confidence in the diagnosis of infective endocarditis definitely rests upon the positive cultures coming repeatedly from different specimens at different blood samples at different times. So, in the overall scheme of things, the cost of cultures is not much. It looks as if, I mean, if I were to tell any patient that I want 10 cultures or something like that, he will be definitely alarmed at what am I talking. But if you really see in perspective, it is not that costly. Neither is it, I think it is money well spent.
Absolutely.
Thank you.
And we have a
Vicky is
Yeah,
very
money
happy.
well spent. I like that. Money well spent.
so to give a perspective, I think our patients spend about $1,000 on cultures itself. But that in comparison to maybe a recurrence, if we don't find the pathogen, would be maybe $10,000. So I think that perspective is easy. I think that question was just to get the actual answer out from all of you, and thank you, Agashe, for that devil's advocate. But he believes in multiple samples himself. So
I was just trying to get an easy way out, if it is there. That's all.
So I had one question, which all of us I think have at various stages tried to find a objective answer as to when can you. This is to both Dr. Choi and Dr. JK. When can you say that on gross inspection you're happy with your debridement, whether it's muscle, soft tissue, bone, or medullary scraping? It's something that you learn over years. It's something that it's a sixth sense, but have you tried and gotten more objective than subjective?
So, to my knowledge,
Intraoperative.
I totally agree to your opinion that what we do is we really depend on a somewhat subjective way, like intra tissue bleeding or like the paprika sign. I think we are depending too much on the subjective way. But I think there are some developments in objective detection methods that you can do intraoperatively, like fluorescent detection or fast PCR. I think those methods really need to be developed fast so we can use in this kind of settings.
I've been doing this type of debridement for the past 20 years. And I'm frustrated about we do not have an objective way to answer our intraoperative questions, whether this is okay or not. And I'm frustrated about that situation. And I'm also kind of happy about that situation because it's not science, it's an art. You need an experience. So I like to be an artist in that sense. So it's not a really terrible thing to, because then you need a experienced surgeon, trained surgeon who's dedicated for this job. That's someone we need to train and develop. And that's my perspective on that. And the other point is that before I had this plastic surgeon covering everything, I was always hesitant to resect. How can I cover this up after that? Then I tend to hesitate. Now I'm very, very aggressive in terms of decision making, whether resect. Even bone now, I told you I can reconstruct 20 centimeter bone now. I have a confidence on that. Then I'm less hesitant to remove whether the questionable tissue, either bone or soft tissue. So I'm really extremely in a lucky position to handle this situation. So that's the reason why we get this nice result with these patients. So I'm representing the cases as a representative of whole teamwork for the past 10 years, really dedicated teamwork. So I'm grateful about that.
Absolutely.
I totally agree with you. Yeah, Dr. Soman.
See, one more comment is, the kind of bugs which we have in especially South Asia, I think China as well as maybe Philippines, but not really Korea and Japan to that extent. We really have an extremely huge problem of antimicrobial resistance. And maybe MRSA rates are almost the same as in Western countries, but the gram-negative bacilli rates of resistance are extremely high. And even not just that, but the kind of resistance mechanisms which we have, I'm sure you might have heard of NDM or something like that. And those bugs are extremely difficult to treat. There is just maybe 1 or 2 drugs in the world which we can use for them. And time and again, it has been shown that the ultimate result depends definitely upon whether you can find a drug which will going to work. Now, if you are talking of something like, say, polymyxins or colistin and polymyxins, we know that their overall antimicrobial efficacy is far, far less as compared to others like carbapenems and beta-lactams. So if you are forced to use drugs like polymyxin because of want of anything else, like for example, this carbapenem resistant Acinetobacter, if it is there, the one which produces NDM, which is commonly present in India, that itself is a big hassle. We don't have drugs. So as a ID physician, sometimes I say that I have more confidence in the surgeons than in my own antibiotics. So again, your strategy of debriding as much as possible, I cannot agree more with you.
Yep.
Absolutely.
In fact, the Menon, in case an objective thing comes up, then people will not be as sincere as all of us in debribing. They'll take things very lightly, very lightly. So it is good that it's not there.
Yep, I agree. So I think we have just about 5 minutes for one round of last questions, if there are, from the panelists. There's just one question from the delegates. If there are none from the panelists, I'll take that up.
Adi, if I may. Just one last question to Dr. O. Dr. JK, you did mention that you've shifted from doing one stage or one sitting reconstructions, with coverage because it just takes too long. The procedure just takes too long. So you've shifted to like staging it. So what do you do for coverage in the interim? Like, do you do negative pressure wound therapy? Do you have any special dressings that you have to do in the interim?
Yeah, mostly vacuum assisted closure. And we still, in minor, in those cases, we definitely need a flap. But my procedure is not a segmental resection. I can do my procedure without CR. Then we still do the flap together. While I'm doing the debridement, he's elevating flap. And once I done the debridement and the PD culture and all that, and he move over. So now he start his procedure in the morning together. So that's something we do nowadays. And then those cases where I really need a serious debridement, I need to bring the CM in, then we stage, and then we like a week interval. And in those cases, we do use VAC. And then I try myself limit the resection of the skin margin at the initial debridement, so that the interim coverage with VAC is not really exposing the whole cement. And then at the time of flap, we resect the more skin margin. So that's how we do it these days.
Thank you. So, any more from the panelists? Okay, so the last question of the webinar. I think this question comes from both Dr. Agashe and me, as well as the one of the delegates has raised this. Is in your protocol, you said you go directly to the non-union site. That becomes your first sample. But what we generally do is go around the infected area till we reach normal soft tissue, excise all of that, and then reach the bone. So you would automatically get extramedullary, proximal, and distal first. Then you would reach the non-union site, and then you would go intramedullary. So that would be the surgical order that we've been doing.
We stress too much about taking these 5 tissue cultures a lot, but like Wonseok stressed during his talk, we do debridement systematically from superficial to deep. And along the way, when we have some deep tissue, infected tissue that may represent an infection or causative organism, then we get the tissue from there. Sometimes we send 11 tissue cultures. Sorry. Sorry, I didn't mention that. But we do debridement systematically, yes.
Okay. All right. Thank you. Thank you. I think hand over to Dr. Agashe to wrap up this fantastic webinar.
At the outset, really thought-provoking and a fantastic way of thinking, totally different way of thinking, which will definitely help people to logically plan their management in fracture-related infection. So I sincerely thank Dr. Choi and JK. Thanks a lot. I also thank Dr. Nilo, Dr. Lu, and most important, Dr. Soman, who is, as Dr. Menon said, the odd man out. Me and Dr. Soman have been together since 1969, rather 71. Now he has shifted to another city, but we know each other that well. So fortunately, he didn't become an orthopedic surgeon. Otherwise, all of us would have been starving. So thank you for... So thank you very much, Dr. Soman. Thank you, Aditya, for conducting this really well. And of course, thanks to EBJIS for this idea of starting Asia chapter. Last but not the least, thank you very much, Ortho TV, for having this platform where so many people all across the world can see this at now as well as at leisure. Thank you very much.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you. Bye.
Thank you, Dr. Choi. Bye. See you.
Thank you. Bye.
Bye-bye. Shall we leave? Ortho
Yes,
TV?
I'm leaving. Thank you.
All right.
Bye.
Okay, okay. Bye-bye.
We'll keep in touch.
Yes, we'll keep in touch.
We will.
Keep in touch.